that? All right, so why don't we get started?
I don't know what you're happy with.
I'm happy with 14, Martin. Welcome everyone. Thank you for joining us. I'm Judy Moskowitz, a professor of medical social sciences at Northwestern and the director of research at the Northwestern Osher Center for Integrative Medicine. The Osher Collaborative for Integrative Medicine is an international group of 7 academic centers funded by the Bernard Osher Foundation to study, teach, and practice integrative medicine. This Directors Series provides a space within which to explore the field of integrative medicine through the sharing of knowledge, resources, and best practices. Each month's session features a director from one of the Osher centers speaking to their unique and shared strengths in the areas of research, education, and clinical care. Before I introduce today's speaker, I just want to say that we're going to try to leave a few minutes at the end for questions, so please put your questions in the Q&A. If you're having any technical problems, go ahead and drop a note in the chat function and we'll help you out. Okay, so today's speaker is Martin Ingvar. He's a professor in neurophysiology and the former dean of research at the Karolinska Institute, and he's the director of the Osher Center for Integrative Medicine at the Karolinska. Today, Martin's going to talk to us about patient-reported outcomes and multimorbidity. And Martin, I will let you take it away.
Oh, thank you. Good to see you all this morning. And I'm really happy to be part of this presentation of what we do at the Osher Centers. What we do at the Osher Centers is really not so different from what we do in other research centers. I should start by saying that, so don't be surprised if you sort of recognize the method and the ideas, etc. I'm working on the challenge on how we should do patient-centered healthcare information in order to drive the validity of the patient's voice in the transformation of healthcare. And one of the problems that we have is, of course, that this is difficult. So we need a lot of money. So I wish to refer to the funding agencies. But so what's the problem we're working on at this point? The problem that we're dealing with is that healthcare is getting more and more expensive. Errors in healthcare is the 3rd leading cause of death in the US, which means that one way or the other, we're not doing it correctly. And we spend about 95% on healthcare and about 3% on prevention, although we know that so much is preventable. So another problem we have is that we innovate new methods, new things, new procedures, but we maintain the old ones. We don't retire or meaningless methods at the speed that we should. So all in all, politics and people start asking, what's the societal value that healthcare offers? And more and more in theory move away from looking at healthcare as something that cures disease to something that should promote other values, a more integrated view on this, saying that health is more than the absence of disease, as for instance the WHO does. I usually start with this one. Hospitals are so 1990, and especially now in the era of COVID, we know how much we can do remotely and how much support, prevention, and follow-up is possible to do in remote settings. When we transform healthcare, there are a lot of theories out there. People-centric, person-centric, patient-centric, salutogenic healthcare, knowledge sharing in healthcare, patient integrity, data integrity is very important for everybody. Concepts like learning healthcare and quality in healthcare and cost effectiveness. Turns out that all these drives for improvement of healthcare has something in common. And that is that they deal with what's the process of healthcare and how do we communicate within working unit and between working units. And by all means, how can we figure out the end result of healthcare in order to drive the transition? So these three entities, the process improvement, the interoperability question, and the analytics question, is something that our group has been working on for the last 10 years. Because we see that renewal of healthcare, if you pay for an old method, X amount of dollars per time you actually perform that procedure, you actually preserve the process, the old process. If you pay for the end result, you become, you stop being dependent on the old method that you had in your arsenal. So part of the problem that we're dealing with is that change of process is conserved with poor reimbursement routines, which also means that areas like integrated medicine and other areas that perform healthcare that is not readily appreciated already in the system, in the payment system, have a difficulty entering into the payment systems. One of the issues that we're dealing with in healthcare is that a patient, being a patient, is just an aspect of being a person. And when you're a patient, you meet healthcare in small glimpses of your life, and you refer between those sites, which means that you have far better, as an individual, far better information on how you feel, how your health is doing, and how your autonomy is developing than people in the in healthcare. And when they don't communicate and don't contain the same information, that means that my health trajectory is getting lost in translation between units. I work with patients like Maria. Maria, she is labeled with COPD, diabetes 2, congestive heart failure, and osteoporosis. She has 10 medications. She has 8 different healthcare contacts, and she has relatives with limited patients. So she feels pretty left out. She lacks, though, a care coordination. She does not have a comprehensive secondary prevention program, and she spends a lot of time coordinating between the instances of healthcare, sometimes to the point where she actually carries her own data between sites because of the poor coordination. Specifically when she moves between specialties and when she moves between care levels. This is one of the big challenges we have ahead of us in healthcare. So if we would like to instead use the concept of person-centered information that we have tried to develop, we recognize that being a patient is just part of being a person. We assume that all information has to contain knowledge that can be consumed both by healthcare and by the patient. We must provide continuity across specialties, healthcare levels, and home and healthcare. We must therefore transform the information processes in healthcare to become a service platform, because that's what the patients are used to these days. Which means we have to build in a planning capability. And we have to jointly have the medical information together with the health promotion material. In order for that to be meaningful, we cannot restrict ourselves to simply specific care questions. We have to deal with the smoking issue, the self-care issue, the secondary prevention issue, the remote care issue, and the drug management in order to provide the full service for the patient. So what is the problem? Well, the problem is that there are so many aspects that we need to deal with. So at the same time we do diagnosis, we have to deal with how we plan the care and the drugs and the lifestyle support and the psychological support and the social support, and do that in a comprehensive manner. So why do we need to do that? Well, we need to do it because of multimorbidity, a dominating feature with an aging population where obesity is abundant and smoking still hangs around. If we look at the healthcare population, about 80% of the hospital burden is a result of patients with multiple diagnoses. And if we look at the multimorbidity issue as such, these are different European countries where we see the percentage of patients with multimorbidity in different years, increasing year by year in Europe. So multimorbidity is on the rise. But if we add data, 2 points of data, namely the rate of the percentage of obesity and the difference in expected life expectancy for men and women, which is a very good proxy parameter for smoking and health equity, and do a little bit of multiplication of those, then we realize that multimorbidity is a direct relation between obesity and that life expectancy difference, which tells us the devastating truth, namely that 2 lifestyle changes would radically decrease multimorbidity. We would improve quite dramatically the cost burden for society if we did good in the prevention area. So if we look at the patient's life across the lifespan, the red arrow, we note that of course they have intermittent contacts with healthcare, but their health is also influenced by, for instance, health promotion and by their health literacy and their socioeconomic standing. But if we look how society spends the money, we realize we spend about 3% in the health promotion area and 97% in the healthcare area. And we know that for every dollar we spend in health promotion, society gets $6 back. For every dollar we get $6 back. That's about what we get. So the problem with health promotion is that it's long time cycles. It needs to be continuous over time, and we need to measure progress. And so in order to build that system, we need to reform our health, the digital support in healthcare. We need to support proactive care and coordination. We need to drive improvements by having rapid feedback. We need to support patient self-management and facilitate the ability of remote care. And lots of us have tried that in a manual way during the pandemic, but I do think there's a lot of improvement we can do there. So what's the issue then? Well, the issue in terms of the process, the thing is that we work more or less without process in healthcare mostly. We have the old style practice, i.e. some healthcare professional that meets a patient, and they do things and document that in the EMR. That's what we call local experience built manual process, or manual practice, I should say. And then in some sites we have added an academic build up on it. That's what you do in academic medical centers. Then we collect the data as best we can and try and get the feedback. The problem with that is that when we go back, when we the time cycle for getting back to the data to the patient is about 70, or not data, change practice is about 17 years. When there's not a pandemic on board. If there's a pandemic on board, it can go significantly faster, but in normal days, it doesn't. And we realize that if we would like to, for instance, copy what they do in other trades in society, we would probably need to go to what's called the industrial knowledge sharing model without making care any worse than it is today. So what we need to do is to build better processes and build better knowledge sharing instruments. And that's the type of information system where we can have the patient, where we always collect the data, where we put the knowledge together on top, and then are able to send the knowledge back. That is based on the fact that we're using a language that's proper to do it. And I'm going to come back to that. So what we do then is that we work in our group, we work with what's called shared decision space and structured information. And structured information is more than just using the correct terms. And we maintain a record both of planned and performed healthcare that follows the patient through the full health trajectory. And by that, we abide to the theory of learning healthcare. So we move away from care-oriented information to patient-centered information. We try to do the same solution for the same problem. That's what's called operational interoperability. We try to use structured data because then we can combine the two streaks of information, namely E-based support and direct healthcare professional support. And we try to deal with the issue of multimorbidity in this environment, and that's quite a unique research area. And we aim to have real-time access for the patients to their data. So the shared decision space means that we deal with trying to understand what does a healthcare professional use, what type of information is used in order to provide a decision. And we realize that it's getting really complicated because it's not all about historic information. It's also contextual information, newly acquired measures, patients' intentions, and measures that invoke new measures all the time. So it's a dynamic process, which means that it's not easy to build a process around it. The only way you can do it is by closing the information loops and do it in real time. So everybody have access to all information all the time. And in order to make that meaningful, you have to start with what language are we using here? What data are we calling in? And how do we monitor the data for the EMR and for the quality registers? And by using these types of industrial standards, we built up an environment where we can allow, first of all, the clinicians and patients to build the clinical pathway, standard pathway together that can be individualized, that can be described in a common language. That's the semantic operability layer. And that can then be instantiated in a software and hardware, which is pretty standard. And since it's properly done from the beginning, it abides to the law of integrity and security, etc., that are necessary for all care systems. And this is just to remind me that to say, for those of you who are real nerds in this, yes, we use all the common standards. That's I'm gonna stop there. In terms of dealing with multiple diagnoses, we have our big project is situated in western Sweden. It's a catch area of 3 million, and we have about 3,000 patients ongoing with COPD, and with an average of 2.8 other diagnoses in the NCD, in the communicable disorder environment. And they demonstrate continually that once we get a full multimorbidity plan on board, all of the other measures, like for instance, subjective health experience, healthcare experience, autonomy, and well-being, all of those they improve radically once we show their participation in the treatment of multimorbidity is important for success. One of the tricks that we have worked with is that outcomes measures is like any quality measure. You measure at the either repeatedly or at the end of a care cycle, you measure what was the result of the care intervention. That can be done with clinical observation, and it can be done with patient-reported outcomes. And we have used the ICHOM system, ICHOM.org, where we have developed standard measurement sets for more than half of the disease burden in society. And we have had patients and specialists that have developed those standard sets internationally. And we've come up with standard set that normally contain some 100 or up to 300 measures that are taken along the care cycle in order to follow the success of the patient in healthcare. We realized after a couple of years that the specialists only talk to themselves within specialty, which meant that if a patient had 2 diagnoses, we needed to repeat these same measurements with slightly different dialect many times. And in order to get rid of that, we just recently published how we could harmonize the outcome measures across all diagnoses. And instead of doing only diagnosis-related outcome, we were able to look at in a sequence from very diagnosis-related to very general health, characterize a number of factors where it was possible for us to get general measures that mirrored important factors for the patient well-being, autonomy, diagnose-specific health, and mobility, and etc. And then we could pack them back into healthcare, diagnose-bound standard sets. And these standard sets could then be combined between diagnoses, which means that if a patient has congestive heart failure, COPD and diabetes, for instance, it means that the patient factors would be the same. If you look at the lower right side, the condition-specific outsets were a bit different, and the outcomes were a bit different, but it was possible to measure them at the same time. So with this, we can not only get a good grip of a healthcare institution quality when it comes to the success of treating a single disease. We can also now, and this is new, we can also now measure the total success of healthcare, or meeting the needs of a patient with multiple diagnoses. And we have started collecting data with this now. There are about 1,000 hospitals in the world that use this system at this date. But we are delayed, like all other big research projects of this type, due to the pandemic. Our main research area was suddenly turned into a acute COVID treatment unit. So we lost our ability to continue collecting data. But we'll start again in about a month is projected, and by end of year we will have the first data out from this system. When we build knowledge in healthcare, we do it by contrasting the effect of right and wrong decision. But that should be data-driven and not driven by anything else. But the problem that we have is we have a very poor characterization of the healthcare process, because all the data generally to this day is more or less just generated by the person who made the decision. So it's the subjective report of the finding of a healthcare professional that actually is used to deem the quality of the decision. So what we have done is that we instead try and work in agreed upon trajectories, mini snippets of life, so to speak, in sequence, in order to solve the same problem the same way when we work. And that method is pretty cool. This means that we work with common concepts. So for instance, let's say we measure blood pressure. So what does that mean? Well, that means that we have a term for blood pressure, and we have all agreed that this is the way it should be done, which means that the blood pressure contains what is measured and how should we measure it. So there is a lot of concept-bound information. But that's not enough, because that's only a measure, and then we could try and understand why it was measured. And there are probably 100 different reasons to why it's done. So what we developed is a second level backpack on top of the concept, which means that we have now the ability to not only measure the blood pressure, but we can also understand if the measurement of the blood pressure was planned, or if it's done already, or if it's not done according to the plan. And for instance, get the understanding, okay, so this was the blood pressure on the third visit to check for treatment effect, which means that we have a second level annotation on all our medical data that uses the common traits of language. It tells us the status of the measurement, if it was planned or not, i.e., and also by reference, why it was done. So the first level, that's the type of data we have in the EMR generally. We have to post hoc derive the idea to why a data was collected. Whereas when we use executable care plans like we're using them, we already pack the information in order to know after we have the data whether it was planned or not, or whether it was forgotten, etc. Which means that our insight into the medical decision process and the care decision process and the planning capability is far better with these types of systems. This is to remind me that this is not uncomplicated. This is a data model that's generally used for health information data. And what we've done is that we've added all the green flags in all the different tables to tell us the reference to why things were done in the care model. The big issue here is that the data model also support what the clinicians really want. They want to know not only what have I done, they want to know what should I do. The patient would like to know what is planned for me, what's going to happen. And they would also like to be able to use the data for knowledge building. And by tying the data to the research plan, we can fully anonymize the data. And by anonymized data means that we can do real-time capture of knowledge straight out of healthcare because the data is richly annotated enough. So why is this important? Well, if you work in the top bar here in the traditional manual way, you have a healthcare professional that supports the patient intermittently through an iterative decision step, which means that no subject is the same. And above all, no quality data is the same. If you instead work with the concept of clinical pathways, you can agree in a group of healthcare professionals and patient representatives that this should be a standard plan definition. That standard plan definition can then be individualized in certain sense, and other stuff should not be individualized. For instance, quality outcome measures, they should be the same whether or not the data or the individual care plan is individualized. And it should above all also allow the patient to contribute data to it. With that principle, it is possible to get standard data out of very variable healthcare. It's possible to retain the individualization abilities, and it's possible to push the what's called the procedural interoperability, solving the same problem with the same method far better. In order to support this, we built both a care to the left and the patient support system, where not so much of the previous data is directly shown, but certainly all the plans are shared between the patient and healthcare. In order to provide the ability for interprofessional care, we have also integrated the information systems across different entities of care. So the specific nursing information and the conclusions of that is available for all other professionals, and vice versa, from doctors to nurses, psychologists, social workers, dietitians, etc. And by doing it that way, we can slowly build dashboards for each of the patients that together gives you a comprehensive view that's available for the patient as a basis to provide both the documentation and the treatment plan. And above all, the planned follow-up, including having the patient report back patient experience and patient-reported outcomes. Both PROMS and PREMS can be reported directly in the system. By doing it this way, we can save visits to the hospital, we can increase the patient access to the hospital, and we can get direct data to cover problems like health equity and care access, and also support via the direct communication, direct information, including information that actually helps the patient to increase the health literacy. We have found that the influence of health literacy is rather important in patient groups that we work with in multimorbidity. It's interesting to see how big this issue is. This type of concept has been tested before. This is an example from Denmark, where they did this type of process work, where they did a very stiff process in a very intervention-oriented type of scheme. This was fast-track surgery for knee and hip, and which made it possible to realize a 40% shorter hospital stay. A fifth of the complications were gone, a significantly better patient experience, and a quarter of the cost was gone. This is possible to do when you have a very intervention-oriented thing, but we have also gotten quite nice numbers when it comes to healthcare within COPD, where we were able to, in a very sick population, these are now this diagram should be updated with the numbers from 19, because we have them ready by now, and they're about the same. We noticed that we actually were able to decrease the number of hospital visits for exacerbations by having a better secondary prevention in these patients. And we also noted when we looked into the other areas, other prominent areas, we were able to demonstrate how these patients had a better experience, but we're still out for the 3-year data looking at survival and the effects of the actual medical effects of the treatment. But we know that the patients feel better, and we know that they consume less healthcare already. So just to reiterate what the system that we have built is all about. It's about the fact that we're trying to plan what is possible to plan in order to minimize the manual decision steps. And we do that by building a local vocabulary in number 5 that we combine with known vocabularies like the SNOMED and ICD-10 and what have you. And with that list is then planned in the local work group to become a local standard process in number 7. So we have a number of processes. We have a standard process for congestive heart failure, one for osteoporosis, one for blood pressure, one for the diabetes 2. Essentially, intermittent checklists that take care of and use a common language between them. So we don't need to repeat things just because the patient has a number of diagnoses. And since we use a planned language and planned processes, we can individualize those care plans in number 10, and we can collect data. We can collect clinical data, collect data from the patient, and we can delegate the data collection for patients that need support to the local caregiver, if that's a nurse or orderly, whatever, that's helping out, for instance, at home. All of that data is collected with a full annotation that I just showed you in that very complex diagram, is then stored in a local data lake. And the secondary use of that data is the EMR, the electronic medical record, where standard text or data as it is transferred. But it can also be used for direct analysis for the dashboard, or for also talk about the research and the pharma view. The pharma industry can get anonymized data. Policymakers can get insight on the group level very, very early on. So this is a very general infographic, just demonstrating the capability of the system. A system, a process like this was built up, and this is done by other people than myself, but it's built on these principles, and that's why I show this. It's actually out it's been printed now. What they did was that they organized a proper standardized care process for congestive heart failure, and they developed a collaboration with 80 open care units in the Stockholm area, catch area of 2 million people, and developed consensus in the whole healthcare community that this is what we should do. Very simple steps, all of them in the national care recommendations. And not complicated at all, but they also allow the patient to just go and show their mobile phone in a lab and get their NT-proBNP, a blood reading for the severity of disease. At any time they felt worse, they were also instructed to use the chat room if they wanted to report an ensuing exacerbation. And by that, they were able to do early secondary prevention for exacerbations. And by that, they showed that the increased referrals of the whole populations for a full professional workup at the specialty level increased over time. The readmissions decreased over time, and they're still decreasing. And the adherence to European guidelines for treatment is now above 75% in this very socially challenged healthcare population. So this is the type of population level effects you can get by proper knowledge sharing between professionals. The informatics level of this is just to tell us that this can be done with already existing standards. We didn't have to invent anything except for a few small tricks. And the fact that we were able to use the common healthcare standard also tell us that we can put much higher demands on the EMR vendors in order to better service the patients and also better service the healthcare professionals, specifically in these days where we try to perform integrated care in a cross-professional environment. So better healthcare rests on the development of shared knowledge capability. Shared knowledge promotes professional interoperability, and semantic interoperability supports shared knowledge. And that's why, since I saw that as a critical unit to improve this, that's why our project has very much focused on that. And we have demonstrated that patient-centered information model supports real knowledge sharing in real time. So we've actually now demonstrated that the concept that we started with 7 years ago has now run full cycle in healthcare, and we hope for an acceptance of this manuscript pretty soon. Which we hope will pave the way to influence more healthcare and above all the EMR vendors to better service healthcare. Thank you. I'll stop there.
Thank you, Martin. What a huge effort. If anyone has, I've got a question, but as we're talking about that one, if you have any questions for Martin, please put them in the chat function or the Q&A. So Martin, I was wondering if you can talk a little bit about the pre-implementation process. So this huge effort where you're bringing together, multiple stakeholders, the patients, multiple providers, working within the EHR. What did you do sort of in the ramp up to actually rolling this out? And how did you make some of those decisions?
What we did was a trick. Which is a bit sneaky. We understand that healthcare is the same as any other industry, except that it isn't. Which means that in healthcare, you can only use healthcare language. If you go into healthcare and use the word service, process, platform, customer, they will shoot you on the spot. So what I did is that I used industrial tools for process development, but I did a translation completely to healthcare language. And then I developed a public domain manual for development of healthcare processes. And it's printed and it's available in English as well. Which means that the work group can develop their work process using their common language of how to do it. And the fact that I used standard industrial models make it possible to take whatever they have developed locally, drive it through the industrial development tools that are standards, BPM 2+0 and other types of very standardized tools, and thereby develop the annotation, the correct semantic annotation of these developed structures. So I developed an interpreter between what healthcare people talk about and patients talk about and the requirements of the semantic level. Generally, it takes 3 to 4 sessions even before you start getting serious about the process. So what we do is a very simple one where we use essentially post-its, and people start putting that on the board and seeing if we do it this way, if we do it that way, and then you run it that way. You make a mock-up and show them the effects of their thoughts in the software, which means that normally they will make a very rich process to begin with. That is taken down to about 40% of what it used in the first trial. That's number one. Number two conclusion is, unless representatives, well-anchored representatives, are included in the development of the process, there will be no acceptance of doing it. So unless they've done it themselves, it's not going to be used. So when I talked about the heart failure study that was done, about half of the budget of that project, half of the budget was used for education and just getting the concept that we actually are part of something greater than just my decision in this room. So your question is extremely well founded, Judy.
So, and when you talk about education, that's education of the providers.
Yes.
Yes.
The patients know exactly what they want. I want to know next time I go to the doctor. I want to know exactly what I should have done before I go to the doctor. I want you to tell me what I need to focus on in order to be able to report back things that are relevant for the decision making. The patient, they really know because they live the process already. Healthcare live the item and the reimbursable unit and the scheduling problem and having to be in time to fix daycare for my own children. I mean, they're in an environment that's actually anti-process in many cases.
Great, thank you. We have a couple other questions here. Any thoughts on applying these systems in specialty care versus more general care? Are there major differences, particularly in the context of chronic degenerative disease?
What we have done is that right now we're implementing it together with primary care and specialty level care. And we realize that we really have to decrease the number of obligatory measures when we go to primary care and really go for the treatable traits type of parameters, so that we see we have the early warning systems for when it really goes south. We do not yet have data to demonstrate beyond the previous big data, the previous big project in congestive heart failure. We don't have data, and well, we have some other projects, but not based on the exact thinking of this system yet to really demonstrate the improvement. We do have data demonstrating that the patients expect us to coordinate better between primary and secondary care. So when they come in with an acute exacerbation to the emergency room, all the data exist and all the plans exist, and they actually know that they're taken care of in a way that's that will affect the plans in a prescribed manner for them. So they don't see that now it's a new person, now it's a completely different way of doing things.
Okay, thank you. Let's see, one more question. How do you get frontline healthcare providers and or patients to actually provide the additional information you need? Yeah, I have the same question. How do you get them to adhere to your protocols?
There are three. First of all, the patients love to give you data, provided that you use the data, which means only ask data from patients that you really want and that you can provide a proper return on their investment of time by telling them that you're doing better, you're doing this, you should do that, you should probably read this in order to get better. So always make a full loop to the patients. We have data retrieval from the patient, which is unheard of, because we always nurture that circle. When it comes to healthcare professionals, it's all about not overloading them with bits and bits of data, which means that we spend tons and tons of time designing an instrument where we digest the data so that we only give knowledge. We don't give data bits. We only give knowledge, which means that we nurture the data all the way to the top. Secondly, we always provide not only individual data back on the patient, but we also provide group level data to the environment. Something that they never see in healthcare. And that makes them so interested in improving their own work. It's really it's really dramatic. The first time you show people in healthcare that it actually matters on a group level what they do in the clinic, the motivation for improvement goes right through the ceiling. The idea that it's fun to work in this place rise to the top. So have you trick,
go ahead, finish your thought.
The trick is simply be serious about feedback and give proper feedback, i.e. understand that the important thing for people in healthcare is to make them feel safe in their professional decisions, which means if I can see the result of my professional decision, I immediately feel much safer. If I don't know anything about my disease, I do as I've always done. So it's a perfect driver for change.
I'm gonna take the moderator's prerogative and insert one more question of my own, and then we've got one more from the viewers. Have you fed the data back to the providers, the hospitalization data? I assume yes.
Yes, but they were so unused to it that it had very little effect on the provider level yet. They are more used to having yearly reports from the quality registers, etc. So we're not big enough yet to make a real effect. And it's very interesting, the trend of having non-healthcare professionals as middle managers in healthcare, which I'm sure also exists in the US, makes it even more difficult to penetrate that layer. Which means that we have an extra project now going there, understanding what the demand, how should the communication be done, what frequency, and what type of data do we need to provide to the policy level and to the local provider level in order to increase and improve the understanding between the healthcare professional level and the management level in the local hospital.
Yeah, another comment in the box here. In the US, patients do not provide data even with high compensation and rewards. Most PRO studies have very poor data completion rates without significant probing and dedicated staff who chase patients down in the waiting rooms. And most providers don't even know what to do with PRO data. So, I mean, I don't know how much these are obstacles for your work as well. Are suites just more compliant than our patients in the US?
It's a combination. They are more compliant, yes, to a certain extent, but that's not at all of the explanation. Mm-hmm. We used to have that exact same issue, but we understood very clearly that very rapid feedback of the meaning of the data for the individual patient was actually the key to be successful. So in a normal PRO, if you do an isolated PRO, just asking them and just, for instance, sending an SMS and asking to SMS back, with no feedback, you get about 50% of the data back. If you send a letter, you get even lower. If you make a call with a nurse, you have a hard time reaching them, and by the time you reach them and ask only a few questions, you get 75%, something like that. We're at 92% of the data continuously in this socioeconomically challenged patient group. And the main reason for that is that it's completely integrated in their care process. Mm-hmm. So when they meet the doctor next time or the nurse next time, they go through together what has been reported in the meantime. So they understand that healthcare really cares about the data that comes in. And we actually guide medical treatment. I mean, medical treatment for osteoporosis, those are vile medicines or vile drugs. They're not very nice. There are other things, and if we don't really discuss medication side effects based on the patient data that the patient gives, that means we do not take it seriously. They don't care about our statistics; they care about their pathway.
Great. Well, it looks like our time is up. Thank you so much, Martin. This has been really, really interesting, and we appreciate your insight and leading the way in this integration of PROMS into clinical care.
Thank you very much.
Great.
I really appreciate you having me. Thank you.